we are still required in every state to meet a very different set of requirements, pay a ridiculous amount of funding, and keep on top of these limitations from a workforce standpoint that have absolutely very little to do with our ability to treat patients in a safe and high quality manner.
I had a friend that has a mental health issue that she was requiring care for and went on vacation to a different state. And her psychiatry said, I am not licensed in that state. I could probably pick up the phone and talk to you, but I would not be paid for that encounter.
The difficulties for entrepreneurs and innovators to put out something that is actually going to operate within the confines of those 50 different rules is unbelievable.
If we continue to seek out solutions in the same direction, we're just repeating the same errors. We need to transform the system in which these solutions are being deployed.
Hi, everybody. Welcome back to Lifers. We have got an important episode for you today with a topic that's really near and dear to my heart, which is health equity. So, welcome Kameron Matthews, who has a new job as the Chief Health Officer of Impact Care, which is on a mission to make community health workers far more accessible. And then we're also joined by Shelli Pavone, who's the co founder of a company called Inlightened, which is actually a business that I've come across in my own capacity as an investor with Scrub Capital. And many of you may know I have this passion to bring clinicians onto cap tables and just get them far more exposure with all these venture backed healthcare startups that we have seen hit the market. It's my view that it's these folks in clinical roles on the front lines that really should have a say in the deals that get done. And Shelley really shares that mission, particularly when it comes to connecting companies in health tech with some of the expertise that you can only really get by being a clinician. So we've got a lot to talk about today. So many things. I want to touch on Medicaid and everything that's going on with Medicaid and the current policy landscape. So many developments across AI and care delivery. And what does all that mean for health equity? And then, of course, how we get more young people into roles that not just to become the next generation of physicians, but also roles that take on care in general, whether that's to be a nurse or a community health worker or a home health aide or something else, as we tackle just so many issues in our society related to this growing aging population and the need for more care. So, welcome to the show, Shelley and Cam. I'm so excited to have you both here.
Thanks for having us. This is going to
Thank
be great.
you.
Okay, so many topics that I promised we would touch on, but I think Cameron, I'm going to start with you and really just have you set the stage for us with this moment that we're in right now in healthcare. It feels like we're at the precipice of so many policy changes. I would say the word that I would use is uncertainty to describe the system that we now have. So tell us from your vantage of somebody who's been involved in the clinical world, the health equity world, who's been involved with startups. What are you seeing out there today, and how would you set the stage?
Goodness, it's a heavy question, but these are heavy times, right? Thank you for that. I really agree with that concept of uncertainty. I think we are struggling within the healthcare delivery system, within public health, within just larger supportive infrastructures, even around other social services, food, housing, and the like. I think we are in general facing a lot of uncertainty around health for our nation. I completely agree with that. I think we are seeing spaces of lack of resources across the board, whether that be individuals like ourselves seeking out specialty doctors, primary care, resources, and the like. But then lack of resources at the health system level. We don't have enough workforce, as you described. We don't necessarily have the digital health connections and capability to stand up those different innovative tools a lot of times, whether it's financially or just even the support that it takes to implement those services. Then I keep thinking at levels of scale beyond even above the health system level. I think when you think about our government programs like Medicaid, Medicare, we're struggling with agreement around how best to fund, how best to lead through these programs, how best to make sure that all people receive services with a level of equity, with enough resources to actually keep them whole, keep them healthy. I think of our problems in healthcare at all of those levels. I think you're right, particularly with Medicaid, because of what we saw with HR1 and what is going to be implemented over the next couple of years. We are going to see just increasing impacts on very local communities, rural, urban. We're going to see not just the impacts on those individuals enrolled in Medicaid currently, but also with the safety net hospitals that they have been utilizing because there won't be as many of those resources as far as the payment being funneled into those health systems. And you're going to see both rural and actually the studies are showing even more urban safety net hospitals going to be impacted, closing down services. And when we're talking about inequities like maternity care and pediatric care and the like, we're going to start to see, unfortunately, even more disparities between those who have access and those who don't. So I hate to paint such a bleak picture. I didn't realize I was that negative until I started talking, but I do think there's a fair amount of positivity, hence my new role, as you described, my former company, other experiences that I have had. I think there is enough of a space within primary care, within community health, within public health, when you think about partnerships in different communities where we can make a difference. And then we can lean on different innovations and models to hopefully address these gaps that I've described.
No, it's actually great because we just had a guest on last week, Sachin Jain, who's one of my
Oh,
favorite people to
yes.
talk to. Sounds like you know him from Scan, and he's been in the world of health plans, but he's also very entrepreneurial. And he said he thought healthcare people have a toxic positivity problem where we really are so reluctant to just lay out the problems. Everybody feels that they have to shift to optimism.
Yeah.
And he's trying to live in a space where he can just talk about the problems and lay them out and be
Hmm.
comfortable in
Yeah.
that space. And so, when you shared that kind of stage setting moment, I personally felt like, okay, somebody's acknowledging this and I'm not crazy for seeing it and vocalizing it.
Mm-mm.
Um, Shelly, set the stage for us in your mind. What are you seeing? And I'm gonna also encourage you to not get sucked into the toxic positivity that Sachin talked about.
Well, I would agree with Dr. Matthews in the sense that things are bleak in a lot of ways, and I'm going to take a slightly more positive take here, and not that I'm glazing over the problems, but looking at ways that maybe we're seeing people try to solve some of the problems. But I think that we can't get to that until we lay all the problems bare, like Dr. Matthews did. But, we are seeing, especially from providers in healthcare, there's a lot of burnout. It is exhausting to try to serve a population of people and see the landscape change as far as regulation and funding, and to see changes in access to care and health insurance. People that get into the medical field are often looking to help people. And there are all these factors outside of their control that are constantly kind of weighing down on the system. What I see a lot of in the environment that I'm in, being on the side of innovation, is the entrepreneurs and the innovators that are trying to come up with novel ways to solve some of these problems. So, from the providers and the clinicians, I hear a lot of what's going on, the way that they feel. We see the hospitals in rural communities and the safety net clinics being closed. We have those fears for individuals whose premiums are going to go up or who may not have access to care at all. And then on the other side, I see the entrepreneurs and the innovators who are really trying to roll up their sleeves and solve these problems. And so I generally have a slightly more positive viewpoint because at least I get to see the people that are trying to fix some of these things. Of course, the providers are too.
So it sort of reminds me of a trend I've seen a lot more recently where in the early days of, being involved with healthcare entrepreneurship, I think a lot of folks were just raising money from VCs and saying technology will be the solution and we will just focus on building the best products. For the most part, that has not worked. And what I'm seeing more now that I would love actually both of your perspectives on is I'm seeing my friends who are running new companies hire lobbying. I'm seeing them get political. I'm seeing them show up on a local level. And if they see that some behavior is happening that does not look right or in the interests of patients or providers, oftentimes the problem is a broken incentive. And sometimes those incentives can only be fixed through things like grassroots organizing and action within your local community. We have all kinds of laws across healthcare, too many to even name, that may have been enacted with the best of intentions and have been twisted into things that now have become very negative, like ways in which we don't allow for competition, which means prices remain artificially high. And there's so many examples of that on a state by state basis as well as at a local level. Cam, you've been involved with startups for a huge chunk of your career. You were at a City Block. I think City Block got the memo early on that. Walk us through that shift.
Yeah, I think I often refer to kind of the definition of insanity, right? Albert Einstein's definition that if we continue to seek out solutions in the same direction, we're just repeating the same errors. And I think what we recognized at City Block, what we recognize, you're right, I think across the innovative space is that we need to transform the system in which these solutions are being deployed, that the limitations we have from a policy standpoint, whether it be around payment, licensure, or from a workforce standpoint, overall, just compliance requirements, healthcare being one of the most, if not the most regulated industries in place, especially from a data standpoint, a privacy standpoint, the limitations we have from HIPAA, all of these prevent our ability to be innovative, to seek out new solutions that are creative so that we can communicate, for instance, in team based care between different specialists and primary care and other care team members that may be focused on one patient, yet privacy requirements, the data requirements, the lack of interoperability from our different systems, all of that are limitations to our ability to place that person at the center and at the lead. So we do need to advocate more broadly. One of the pieces that impacts at least the frontline workforce most significantly is not just for physicians, but nurses, even community health workers, pharmacists, is the licensing requirements. That's actually mainly at a state level. But the fact that in every state, when we're now in this digital telehealth space where we can be bringing down the requirements of brick and mortar and being in person, we are still required in every state to meet a very different set of requirements, pay a ridiculous amount of funding, as I'm very acutely aware of, and keep on top of these limitations from a workforce standpoint that have absolutely very little to do with our ability to treat patients in a safe and high quality manner. It's just a regulatory structure at the state level that needs to be changed and that forces different models to change from state to state. That's one of the issues with Medicaid, right? That's one of the reasons why it's so difficult because we have a very different program from state to state. That's the nature of the program. But when you're looking at licensure and workforce, there's also very different requirements from state to state. So when I want to stand up, for instance, a pharmacist program in one state, but I can't do it in another, how does that affect us from a model standpoint within our company? Because we really can't go to scale because of the lack of standardization from state to state.
It's so broken. I agree. And I had a friend that has a mental health issue that she was requiring care for and went on vacation to a different state. And her psychiatry said, well, I'm not licensed in that state. I could probably pick up the phone and talk to you, but I would not be paid for that encounter, and I'm technically not allowed to. So, we talk about the importance of continuity of care and we use all this language. And then on a practical level, that is the kind of thing that impacts patients day to day. Shelly, you'll find this funny, but a few years ago, I sent out a message on my old Twitter account back when a lot of people in medicine were on Twitter. And I said, can anybody give me an actual rational explanation for why we have this state by state licensure apparatus? Is there something that I'm missing? And I could not get, nobody could tell me why, except somebody said something along the lines of, oh, maybe it's different. There are slightly different conditions in each state that might arise. But to me, that seems like a very weak argument for everything we give up and all the additional hurdles and complexity. You interface with medical experts day in, day out. Have you seen this be a huge source of frustration. Do you see any potential solutions here?
Yeah, I mean, it's such an interesting thing to consider because I work with this problem as it exists day in day out, and I guess I haven't myself even questioned like why, it's just kind of like that's the way it is. You have to be licensed in every state, and part of what we do at Enlightened is staffing people on clinical trials, and we also work with a lot of telehealth companies and organizations that do remote patient monitoring. And, we have a couple of clinicians that are licensed in every state in the country.
There are not many. I think it's like 20 total that have all those licenses.
And we have a handful that are part of the Enlightened network. The time and effort and money it takes to be licensed in every state in the country, and they're so in demand because of issues and differences for these companies to launch and kind of have a continuity of care and a continuous operating model. When you're having to constantly go to different clinicians, we're constantly asking for these individuals who are licensed in all 50 states or multiple states. It's wild to think that I haven't even sat and considered myself, like, why is that the case? I mean, and then to go back even further to think about the insurance requirements and the way that the state-run programs are accomplished and the difficulties for entrepreneurs and innovators to put out something that is actually going to operate within the confines of those rules for 50 different rules is unbelievable, and it takes a lot of effort to get that done. And I like what you said about the incentives, and the innovation can't exist in a vacuum. And I've had so many conversations with entrepreneurs who are building something that is truly beneficial to patients. But in my conversations with them, being that my background is in go to market and something can't help a patient unless you can actually get it into the hands of the patient or into the provider who's treating the patient, they're unaware of the insurance or the regulatory issues or the incentive structure that it will inherently make this a solution that's really unable to get to the patients. And so it's great to hear that, we see entrepreneurs lobbying and working more within the political sphere because I mean, unfortunately, without those things, it's very difficult to get new things brought to light.
Yeah, I agree. I did a piece on this about physicians who have all these licenses, some of them all 50 states. And these startups basically have to raise venture capital money to fund the process of getting these physicians so many licenses because each license is tens of thousands of dollars and requires a lot of upkeep. And of course, the question then becomes you've just created an asset in this process where, this individual can walk into any telehealth company anywhere in the country and be paid millions of dollars a year because this is such a coveted asset. So, what is the risk associated with trying to train one of these people or trying to get somebody on the team, all these licenses versus finding somebody who already has them? I mean, it's wild that this is the kind of question that a telehealth company in this country has to be thinking about. It's crazy. To pivot slightly, I think one of you, I believe it was Shelly, mentioned that we're very resource constrained at the same time that we also have a system that is the most expensive somehow in the world. And Cam, you mentioned that the job of being a care provider, whether it be a physician or an allied health professional of some kind, has gotten more challenging than ever before. So when you get these emails, these calls from young people saying, I'm considering a career like yours, I want to have an impact. What do you say to them? How do you get them excited? But then also, how do you ensure that you're telling them the real story?
I talk with students almost on a daily basis. I do a lot of work through my own nonprofit, through a student organization that I still work with as an alumni officer. And I think first, I applaud them for recognizing that they are needed, that there is a problem that they want to solve. So many students come into the area of healthcare recognizing that there's a problem, recognizing that one of their family members or even themselves are having difficulty and they want to be part of the solution. So I applaud them and really try to motivate them to continue to understand the problem first and foremost before they commit to what the solution may look like. So many students come to me say they want to be a pediatric cardiologist or they want to do OB-GYN. And there's so many different opportunities within healthcare, within allied health, where they could be really part of a larger solution, could be still at the forefront of innovation and transforming the system. I hope to keep them as educated on the healthcare system as possible and not to think inside a bubble. A great deal of them are coming from under resourced backgrounds. And I also applaud them for recognizing that we need them just as much as we need other students maybe that are coming from top 20 schools or that have the financial capability to apply to dozens of school at a time. I want them to recognize that the diversity of thought, regardless of, and I'm not just even talking race and ethnicity, the diversity of thought we need in healthcare to continue innovation and solutions is going to come from them. So the fact that they are coming from different backgrounds, different geographies, different levels of ability, different languages, different cultural, religious backgrounds, I absolutely love that they're seeking out to be part of a broader approach to solution. And of course, they're at the beginning of the path, but they need to stay motivated because it's a marathon and they can get very easily not just distracted, but dissuaded. Because so many of us who are at my level are burned out and are going to try to turn them a different direction. So I try to offer the motivation to keep them on that path.
And are you seeing a lot of them wanting to go into real role that involves being a provider of care throughout their lives and having a large patient panel and whatnot? Or do you see there being a lot more interest in a more entrepreneurial path where perhaps they go through residency programs, get some experience practicing medicine, and then start companies or join companies or become independent? How do you see that manifest with this generation?
So over the past, what have I've had my nonprofit now for about 13 years. So for more than a decade, I've seen that transition. I love that you're pointing that out. A lot of these students are actually coming into decisions around becoming a healthcare professional with prior experience, with other business background, with other nonprofit work that they've been able to participate in, with global perspective. They're coming at this with a great deal of interest, not just joining a company, but founding a company of trying to think outside of the box and of having some experiences where they were already exposed to that sort of effort. I think it's just what our system needs. I think particularly as I think about students interested in public health, the fact that they are coming more with interests in media and communication and marketing, as we're seeing now around how we really need to assure that healthcare is speaking the right message, using the right language, reaching the right audiences. There are more and more students interested in that piece because they're seeing the impact that we can make on podcasts through social media like this. And they're interested in getting that clinical experience, but also being that voice. They love social media and they want to remain a part of that. But I think that's a direction we need to embrace and expand into our education and bring students along so that we can really promote stronger health communication as a whole. I've been really proud to see more students speaking up in that direction too.
So I have so many more questions to ask on this entrepreneurial trajectory, but you mentioned something really, really crucial that I know Shelly thinks about too, which is putting out good information on social media that I think can actually play a role in combating the bad information that's out there on social media. And I think folks have thought for some time now that the social media companies will, take on this problem and ensure that only the best evidence-based scientific content is shared. And I think now we've had a come to Jesus moment where we've all realized that that is absolutely not going to happen. And it is incumbent upon us to do that work, to get on TikTok, to get on Instagram, to get on the podcast, to disseminate the good information so that it has a chance against, all the snake oil that's out there that I think is truly causing harm. But at the same time, Shelley, I have this phrase I use a lot, which is clinician on clinician crime. And it's to see a lot of clinicians being very judgmental of others in their peer group and in their field who are taking this on, who are being strong communicators and saying, oh, but you don't have as many accomplishments as I do. You don't have as many years of practicing medicine as I do. I have more papers. Why are you getting to be the person that, has has been invited to speak on a topic on MSNBC or whatnot. And you see that all the time, this kind of judgment. So share with us a little bit about where you think that comes from. And if you are a listener who is a clinician who wants to do more of this, who wants to be a public communicator, what are some of the things that you've seen work very well?
I think for anybody who is using a platform to speak out and to share their viewpoints and to share their expertise, there will always be judgment. You can be a physician who is early in their career and have valuable information and insight to share with an audience, and you're going to be looked at like, you don't have the credentials to share that, or you don't have enough expertise. You can be a physician that's much further along in their career, highly decorated from the standpoint of degrees and studies, and people will say that you're out of touch or that you're too old or not in the new science. So I think that ultimately, if you're sharing your viewpoints in a public spectrum, you're going to be judged. And so I think that we need people that are going to be out there sharing the truth. And I'm a big podcast listener. I love listening to podcasts where there are physicians talking about things, even just as it relates to, women's health and things that are not typically talked about or that our primary care providers aren't always well versed in. I have learned so much just about my own health from hearing these physicians speaking out online. So I think it's incredibly important to have those voices. And I think it's incredibly important to have diversity of voices. As Dr. Matthews was saying, we want the diversity from racial and ethnic perspectives, but we also want diversity of experience. I want to hear from the people that are earlier in their careers speaking out. They have a different perspective than those that have been in healthcare for 20 or 30 years. If you're willing to come to the table with real science, evidence-based information and a unique perspective that belongs to you alone, I think that that's amazing. And, there are a lot of people who would not learn anything about their health or healthcare if it weren't for these people who are speaking online, having a platform. And it's just the way the world works. If you have a platform online, you're going to be the one who's asked to go on MSNBC because you've got a presence and a personality that people are familiar with.
I so agree with that. Everything you said about, I had 2 kids and I was after my second kid feeling just exhausted. And I follow a hematologist on social media. I would never have thought to see a hematologist. And she put out this tweet. She said, PSA, women who've just given birth, check your iron levels. I took it upon myself to go to my PCP. I asked for a test and I had a ferritin level of 6, which is extremely low. And almost immediately started iron supplementation. And I felt better within a matter of several months. And I've really fixed it. I don't even know how bad that problem could have gotten. But to me, it's not reality to say that patients should be fully reliant on their primary care physician to tell them to do all of these things when so many people don't even have a primary care physician. So we need to face this reality that patients are going to be more proactive. They are going to seek out expert voices. But then I think the problem, Cam, and I would love to hear your thoughts on this, is that some expert voices are far more credible than others. And we're asking a lot from patients to have to discern who are the people to listen to and who are the people to not listen to. How would you speak to that?
That's the issue. And I think you hit on the point there, particularly around having a primary care relationship, right? Having a continuity relationship where you can go to someone that you trust. The larger conversation now around communication and trust and expertise, especially on social media, is one where we're recognizing that it's not just our degree and our title that's providing the foundation for trust. People are trusting other individuals they're connecting with on social media that they believe are providing, unsolicited advice and information. And they have nowhere else to turn, to be honest, to really be able to question that information, to get more personalized approaches to how to address it. I mean, I absolutely love that you heard of that recommendation around iron deficiency and you went to your PCP, but a lot of individuals don't have that person to turn to. So they'll continue to dig in further and let the algorithms take over. And the information, unfortunately, is not always as well evidence based as it should be. So I myself as a PCP, I am hoping for more transformation around our primary care system as a whole. I think part of the reason why the wellness industry has sprouted up with such involvement throughout all social media is because we don't have that primary care relationship where you can go and talk about other non-pharmaceutical options, right? Or other ways to prevent disease, to prevent chronic illness and the like. So we're turning towards wellness and we're listening to individuals. And that's where we're leaning in with trust. I don't in any way begrudge anyone from learning from individuals, but I do get fearful when you don't also have someone to turn to talk about the personalized approach to how it might impact your healthcare, how those recommendations might be deployed more personally. So I think we need to think about broader opportunities for all of us to have a primary care person, a primary care clinician that we can turn to, that we can have these conversations. And I think that for me personally is where I'm seeking out larger policy transformation around how we value primary care in this country, how we train a workforce to do so, how we pay for primary care so that they can be more established opportunities within communities, whether it's a smaller private practice, a federally qualified health center, a larger academic medical center. Primary care practices are struggling to keep their doors open. So that's why they're forced to do this volume based care in our current payment structure to see more and more patients with less and less time. None of us trust that system, right? You may trust that doc, but you don't trust the system in which, unfortunately, they're made accessible to you. And I think we need to change that. So that's a long term solution, I completely admit. But I think perhaps finding other sources where you can have that conversation off of social media with someone who can really lean into your healthcare, whether it's through telehealth and the like. I think that's probably our short term way, but I do promote that all patients find some level of continuity, not just walking into an urgent care clinic or talking to a single provider on telehealth, but getting to know someone who knows your history and who can make appropriate recommendations.
So there's a lot of people in Silicon Valley that think the short-term solution, potentially also long-term, is AI, something more autonomous than we have now, perhaps AI supervised by a human primary care physician. But the idea is that patient panel sizes expand even more with so much of the work being done by AI. And I think there is some thinking of, take prescription refills, for instance. Can an AI do that and leave a PCP to focus on something that might involve a real dialogue with a patient to get to the bottom of something more complex? So I hear those things, and to me, it sounds more reasonable and, like a potential next step. But then you hear entrepreneurs talking about the full bore replacement of a primary care physician with an LLM, and that is the answer to this problem that we face, our supply and demand mismatch. Where do you fall on this spectrum?
I'm smack in the middle there. I do look forward to a day where AI can take over the menial tasks that my degree does not in any sort of way set me up for. There's chart summaries, there's prescription refills, research, and other more care management tools that could help not just me, but the team that I work within. Because I also think we're a bit short sighted in thinking that innovation is just about replacing the doc. There's a lot more care that actually needs to occur and that could be optimized if we also look at the administrative, just menial tasks that broader technology could be assisting with. But I am very much hesitant to take it all the way to a space where an LLM is going to replace a physician. I think yes, it's a tool that I use every day that I will continue to use. But the relationship that I have, the continuity that I have with my patients is more than just informational. It is more than just spitting out a diagnosis. It is about human interaction, is about motivation, it's about shared decision making, it's about judgment calls that the AI is not yet trained on, perhaps in the future, sure. But it is about that human connection that, yes, I've seen the studies. Everyone keeps referencing the AI that it has higher empathy. In a single conversation about a single topic, AI can come across.
And I did see a good rebuttal of that from a physician who said, Instead of doing this study with a primary care physician that's got 6 minutes for a visit, you should do this study where a primary care physician can actually sit there
Yes.
and spend real time with the patient and then compare that to the AI, because that is a lot more of a fair study. And I thought that was a good point.
That's exactly the point there. So I think using it to allow me to have this direct conversation, whether it's on a screen or sitting in person, using tools to allow me to pull away from my keyboard and have that conversation, to make that connection and to motivate and help them self-manage, to help them find new tools. Yes, all of that is possible through an AI chatbot, but the totality of all of those pieces and to really be able to partner with my patient. I'm not in full favor just because I haven't seen the tool yet, and I'm nervous about replacing that human perspective within primary care and even broader than primary care. I think there's a fair amount of judgment call and shared decision making that the AI is not going to be as suited to replace.
I think that's right. Ladies, I'm going to lead us into a rapid fire round in our last few minutes. I'm going to ask you 3 questions, and both of you have an opportunity to respond. You can respond with your answer or give us a little context too. Um, so, my first question, let's call it the short term, let's say the next decade, what do you think will have a bigger impact on patients' health and well being? AI or GLP-1s?
GLP-1s by far.
Okay, and I would I'd love to know more about that. Why do you say GLP-1s?
I think very individually about a number of friends, patients, colleagues who have had life-changing weight loss, control of their diabetes, control of other diseases, hypertension and the like due to the weight loss and not. I think we're gonna continue to see the prices come down. I think we're gonna continue to see the market expand with other solutions beyond just the Wegovy's and the Zepbounds. I think with that, we'll have broader access, and I think we'll make them more available to patients. And so the immediate impact, as opposed to what I think we're seeing very slow impact from AI as far as change in outcomes. We're seeing that immediately from GLP-1s. And so I think in that time frame, because access will increase, we'll see more of an impact from the GLPs.
Shelly?
I agree. The GOPs, I think it's the impact on patients 100%, especially because of weight loss, but all of the things that come along with weight loss and better cardio function, especially with all the research that's been coming out around metabolic diseases and the ability for GLP-1s to impact those. And I think we're just scratching the surface. I agree with Dr. Matthews. If we have better access, I mean, that is changing lives in the near term. And I think that it will continue to impact people and have longer term impacts on their health than we had even thought in the beginning.
Love it. Every time I ask that question from a, Silicon Valley type, I get AI, and
Love
most
it.
physicians will say GLP-1. So,
I love it.
okay, so my second question, there's so much talk about the deficient education related to medical school. There's not enough training in nutrition. There isn't enough training in the business side of medicine and how money flows, endless, endless things. Not enough training in bedside manner and empathy. If you get one thing where you can fix medical education and create a whole new syllabus around one thing, what is that thing?
And if just the single thing, because I have a list.
That's why this is
It's
hard.
hard. What is the number one, Shelly? If you have something, jump in.
I mean, I'm going to say more specifically women's health, menopause, late stage, women's hormones. That to me is an area where I think that, you know, the education is lacking in among many others, but that would be one.
I think, especially with the recent CMMI model coming out, the Elevate model, the Maha Elevate around lifestyle medicine, I actually think you hinted on nutrition, but I think up front around kind of the 6 pillars of lifestyle medicine, which include nutrition, physical activity, all of that is about preventing chronic disease and allowing for people to self manage their own health. We are taught very little about that. So I'm a huge proponent of leaning into what we call lifestyle medicine. I think our students need to first and foremost be able to talk to a patient about how better to treat their diabetes through their diet as opposed to writing a prescription. And that goes across the board for avoiding substances, sleep management. Again, there's 6 pillars within lifestyle medicine. And more schools are starting to adopt those curriculum, thank goodness. But that would be my number one choice so that doctors can start to lean into these concepts of prevention, wellness across the board, regardless of what field they go into. Because right now it's being seen as purely primary care. I think we need to have broader ownership of that across healthcare.
Okay, last one in this rapid fire round. If you could only name one person who you think is the unsung hero in healthcare today, who maybe doesn't get the recognition that they should, is there anybody that springs to mind? I'll give you one. I think he's kind of sung, but he's not totally unsung. I think I'm going to give Mark Cuban my award for the moment because
Whoa.
I really appreciate that he actually is using his microphone to talk about the topic of drug pricing and explain the whole, backdrop of the space, the PBMs and whatnot, how it all operates. And people say, oh, he's not entirely accurate 100% of the time. But to me, the impact that he's having and getting people to care about this issue that is extremely impactful to so many patients and that he's using his podium for that, like to me, he's my hero of the day. But if you ask me tomorrow, it's going to be somebody else.
Yeah, yeah. Well, naming Mark makes me think of a dear friend and colleague. She's getting a lot of attention, especially in the public health space, and what she's doing up at Yale, the dean of the Yale School of Public Health, Megan Rainey.
Oh, I love Megan. Yeah.
Absolutely phenomenal. She's really expanding these conversations around trust and communication. I listen to everything, read everything she puts out. And especially in the wake of the mass shootings earlier this week, she had a very good conversation around gun prevention most recently. And she's really leaning into conversations with MAHA audiences, with broader academic
She's so
audiences, and
brave.
the like.
She's amazing.
I'm learning a lot from her. Yeah.
Yeah. And she really goes there. When I was at CNBC back in the day, I covered COVID and, she was definitely one of the voices that was unafraid on the front lines, as well as being an emergency medicine physician. So I think that's a very strong choice. Shelly, you want to give yours?
Yeah. I would just say overall, it's the support staff in healthcare, the nurses, the people that are kind of, doing the intake on those patients that are angry because they don't get the time with their primary care physician, the ones that are fielding those questions, the nurse practitioners taking on a lot of primary care these days. That would be my answer.
It's a great one.
I love it. I love it. And in my new role with impact care, leaning in with community health workers that are serving a parallel but not direct role, but thinking about I was just listening to a podcast where they were describing a documentary around certified nursing assistants and their role in long-term care. I think there's just a great number of roles within our care teams that we tend not to place at the lead. They tend to get the real scut work. They tend to be unfortunately not receive the amount of gratitude. So I think that's a great choice, Shelley.
Yeah, 100%. And any patient would say that it's the nurse that, that checks their blood pressure and smiles at them and asks them about their day and makes sure they've been fed. Like that's the person that, really they feel gratitude towards, not just the physician who checks in during rounds. So thank you, ladies. This has been an incredible conversation. We touched on so many different topics as I expected that we would, but I think it really gave me strong thinking that we need to do a part two because there was so much more to say. So really appreciate you joining us on the Lifers pod and being lifers and sticking it out. There are easier jobs, easier sectors to work in, but you continue to show up for healthcare and to want to fix healthcare every day. So thanks, ladies.
Thanks, Christina. This is a great conversation.
Thank you so much. Really enjoyed it.
That's a wrap on Lifers. If you know someone else grinding it out in healthcare, send them this episode. And if you want more unfiltered takes on digital health, check out the Second Opinion newsletter, link in the show notes.